Bom, boa tarde a todo mundo. Continuamos hoje com nossos ciclos seminários de doenças crônicas e infecciosas, que está tendo muito sucesso, com mais de 90 alunos participando e pesquisadores do país todo e também de alguns lugares de Latinoamérica e de Europa nos prestigiando. Então, a gente hoje vamos a ter como moderador ao professor Fernando Genta, pesquisador da Fiocruz de Rio de Janeiro, que ele tem uma convidada de fora do país. Mas eu vou deixar a ele apresentar, depois de passar por nossa sessão, que já está tendo bastante sucesso, bem esperada, que é um minuto da glória de cada um de vocês para se apresentar. Até Bruna vai começar hoje, e vamos dar passo à sua apresentação. Bruna tem 1 minuto e com você a palavra.
Obrigada, professor. Boa tarde a todos. Eu sou a Bruna, sou biomédica por formação. Atualmente eu faço doutorado na Universidade Federal de São Paulo, na UFPR, no Departamento de Microbiologia e Imunologia. Sou orientada pela professora doutora Érica Suzuki de Toledo, e nós trabalhamos na área de pesquisa de biologia celular da interação fungo-hospedeiro. Então, no meu doutorado, eu trabalho com a interação, a resposta de células epiteliais pulmonares humanas frente à infecção do fungo patogênico Paracoccidioides brasiliensis. E eu gostaria de agradecer ao professor Marcel pela oportunidade, por ter difundido esses seminários para outras universidades. Está sendo bastante gratificante para mim participar. Obrigada.
Obrigado, Bruna, pela sua apresentação. E eu já lhe comentei no e-mail, sou vindo daí, do seu departamento, passei 9 anos aí, mestrado, doutorado, pós-doutorado. É um prazer ter uma alumna da Unifesp entre a gente, tá? Obrigado pela sua apresentação. Vamos continuar com Jaciela.
Boa tarde. Eu sou Jaciela, Sou aqui de Pernambuco, sou formada em Ciências Biológicas, com ênfase em Ciências Ambientais pela Universidade Federal de Pernambuco, e atualmente eu estou no meu curso de mestrado, na Fiocruz, Pernambuco, onde eu sou orientada pela doutora Maria Alice Varjal, e eu confesso que a minha área de pesquisa não tem nada a ver com biologia celular, mas quando eu vi essa proposta desse seminário, eu decidi sair um pouquinho da minha zona de conforto, porque eu trabalho com controle de Aedes aegypti. Então, a pesquisa da gente é mais voltada para campo. Então, eu vi nesse seminário a oportunidade de sair da zona de conforto, aprender novas coisas e também complementar, ver a aplicabilidade, porque eu estou pagando também uma disciplina de biologia molecular. E eu vejo lá a teoria, e quando vem aqui as pesquisas, a gente consegue casar, a teoria com a prática. Então, isso está sendo muito enriquecedor para mim, e agradeço ao professor Marcel por essa oportunidade.
Obrigado, Jaciela. Eu que agradeço a presença de Pernambuco. Eu já demonstrei meu carinho pelo Nordeste na apresentação do professor Roberto, e para mim, muita felicidade ter você presente. Então, obrigado pela sua apresentação. Josimara.
Boa tarde a todos, sou Josimara. Eu sou biomédica pela UFPR e atualmente faço mestrado na Fiocruz, Pernambuco também, como a Jaziela. E meu trabalho envolve a vigilância em filariose linfática. Eu estou um pouco distante da cadeira, mas eu tenho muito interesse. Inclusive, assim como a maioria das pessoas, gostaria de agradecer ao senhor professor pela oportunidade de participar de momentos tão valorosos quanto esse, A cadeira tem sido muito interessante para mim.
Obrigado, Josimara, pela sua apresentação. Obrigado também por suas brilhantes respostas nos questionários, tenho gostado muito.
Obrigada.
E a gente não... conheço a cada um de vocês, acreditem que não leio as respostas. Não, eu já sei bem e eu agradeço a participação. Michelle está um pouco inquieta. Para fechar hoje no nosso minuto, Michelle de Marchi.
Boa tarde a todos, eu sou Michelle, sou graduada em Biologia, fiz um mestrado em Biologia Celular e Molecular aqui pela Universidade Federal do Paraná. Agora estou indo para o segundo ano do doutorado, no mesmo programa de Biologia Celular e Molecular. E desde o mestrado eu venho, então, avaliando o efeito de poluentes ambientais na malignidade e progressão do câncer de melanoma. No mestrado eu fiz o estudo in vitro e agora no doutorado estou dando continuidade com o estudo in vivo. Então, basicamente isso, agradeço pela oportunidade, também agradeço ao professor Marcel pela disciplina, que está sendo muito boa, de muito aprendizado, ainda mais nesse momento atípico que a gente está vivendo, né? Então, eu agradeço pela oportunidade.
Olha, eu que agradeço, Michele, pela sua presença e por aproveitar a disciplina e todo esse empenho e dedicação. Gente, obrigado a todos os alunos que conheci agora, já conheci antes pela forma escrita, agora vamos a dar passo a começar esse seminário. O apresentador e o moderador de hoje é o professor Fernando Genta, do Instituto Fiocruz de Rio de Janeiro. Ele é um membro ativo da comunidade de insectos e interação parasita-insectos. Fernando Genta conheço dos tempos que eu trabalhava no Rio de Janeiro, e Fernando é uma pessoa de destaque em comunicação em ciência. Então, para mim, é um orgulho tê-lo aqui, porque ele vai deixar de participar num prestigioso e conhecido Artropódium, que reúne as grandes figuras de insectos e de pesquisadores e alunos de diferentes lugares do país, e hoje ele nos trouxe uma convidada estrangeira, e é para mim assim, uma enorme alegria ter Fernando, que já nos deu um seminário de muita qualidade o semestre passado, então ele estava na primeira lista para pensar se ele poderia moderar e trazer um bom convidado. Eu agradeço a Fernando a sua disponibilidade, a sua paciência agora para esperar a gente começar. Fernando, é com você a palavra.
Obrigado, Marcel. Eu vou apertar a tecla SAP. Né? Ivy, can we start? Okay. So I will present you very quickly, then you can share your screen. I think we should, first things first. So it's a big pleasure to me to present Professor Ivy Hurwitz. She's how can I say, a very good friend of mine. We met, I think 5 or 6 years ago, starting a project together, working with larvicides against Aedes aegypti. She has a very interesting trajectory in working with vectors and paratransgenesis, and now with this huge project with the CDC, which is being how can I say, it's been a great opportunity to work with you, Ivy, in the last years. And I had the opportunity to visit her lab in Albuquerque and in the US. Beautiful place, amazing laboratory, very nice people. So I recommend everybody to visit Ivy's lab, especially well, after the pandemics, obviously. But when I invited Ivy, we had a very quick discussion, because she had to stop the work with vectors for I think more than 1 year, to focus in the COVID-19 emergency in New Mexico. And I'm pretty sure she did that with great competence, and I'm very curious to see these results of her group. How can I say? I'm pretty sure it's a very good example of response of the research laboratories to a health crisis, and I think we will have a very good example of that today. So Ivy, thank you so much for joining us today, and I think now it's up to you
Okay. Thank you so much. Thank you so much for having me and for inviting me, Fernando. It is such a pleasure to be sharing our work with you. Okay, so I have really not done Google Share before, so let's see if this works, okay? I think I just say, okay, so we should start. Okay.
Yes.
All right. So thank you again for having me. Okay. So we can start, right? Should we just do it?
Yes. Yes.
All right. Okay. So as Fernando mentioned, for most of my career, I have worked in methodologies to control vector-borne diseases. And, you know, Fernando and I met, like he said, about 5 years ago when we embarked on a project to develop novel larvicides for mosquito control. But as a result of the pandemic, our larvicide project had taken a back seat as our team at the University of New Mexico have had to refocus our efforts to support the national crisis. So our team have been involved with several COVID-related projects. And what I would like to share with you today are some results from our work looking at the impact of viral load dynamics on disease severity in different racial groups here in the US. Okay, all right. So let's start with a short background or overview of coronavirus. So as you're probably aware, the coronaviruses are envelope viruses with positive strand, single-stranded RNA genome, and this is all covered by a nucleocapsid. They are amongst the largest of the RNA viruses with a genome size of between 26 to 32 kilobases. So when these viruses were first observed by electron microscopy, they have this characteristic fringe of bulbous projections that created an image that is reminiscent of the solar corona or a halo. And that is where these viruses got their names from. So now we know that this morphology is caused by the viral spike proteins. So coronaviruses are actually quite common. Up to 30% of all common colds, for example, are caused by 4 different strains of coronaviruses, shown right here. So the family of viruses became famous in 2002 when SARS-CoV-1 was identified in Guangdong province in China. And this little epidemic resulted in 774 people perishing. About 10 years later, the Middle East Respiratory Syndrome coronavirus, or MERS, was identified in Saudi Arabia. This strain spread to 29 countries, mostly in the Middle East, and resulted in 858 deaths. So in December of 2019, SARS-CoV-2, the causative agent of COVID-19, emerged from a wet market in Wuhan, China. So as of this morning, they are close to 137 million global cases of COVID-19. They're close to 3 million deaths, half a million and close to 355,000 people have perished in the US and in Brazil, respectively, as a result of this very devastating disease. I'm going to share with you now some slides from the COVID tracking project showing US nationwide COVID-19 metrics from April of last year to the beginning of February of this year. We're going to concentrate on these 2 middle plots. The one on the left shows the number of daily cases, while the one on the right shows the number of people that were hospitalized with COVID-19 during this period. So not surprisingly, there is a correlation between the number of COVID-19 cases reported and the number of people that were hospitalized during this time period. So in the US, the number of hospitalized persons peaked in about January 6th of this year. There were about 130,000 admissions, and it has since declined to about 35,000 hospitalized patients as of about a week ago. So as you all are probably aware, there are some ethnic and minority groups in the US that are disproportionately affected by COVID-19. This point is made abundantly clear in this plot where hospitalized patients are stratified by race. It is very clear that cumulatively, people of American Indian, American Native ancestry have a much higher hospitalization rate, and this is followed by people who identify themselves as Black or of Hispanic descent. This next slide shows death due to COVID-19 per 1,000 people by race and ethnicity. Nationwide, we see that African Americans and American Indians have died at a rate that is 1.4 times higher than white people. So this disease burden to the people of American Native ancestry becomes even more significant when one takes into account that this group of people accounts for under 2% of the US population. So I'm gonna take you on a quick detour to kind of orient you as to where New Mexico is located. Here's a map of the US. New Mexico is located right down here in the southwest corner of the country. This map up here shows is basically New Mexico. So you can see we are surrounded to the east by Arizona and Utah. To the north of us is Colorado. To the east is Oklahoma, and to the south we have Texas, and then Mexico, which is our closest neighbor. Albuquerque is located right here, kind of in the middle of the state, and we are in a county called Bernalillo. To the west and north of us are three counties, namely Cibola, McKinley, and San Juan. The three main towns in these three counties are Grants, Gallup, and Aztec. So I'm going to ask you to remember these three towns because I'm going to show you in the next slide a map of the Navajo Nation. So the Navajo Nation is shown here in this orange color. This is an American Indian territory that covers about 17.5 million acres, and it occupies mainly parts of Arizona, southeast Utah, and in northwest New Mexico. So remember those three towns that I had mentioned earlier? Here's Grants, Gallup, and Aztec. And as you can see, the Navajo Nation is sitting right in the middle of this area. Albuquerque is right here. We are about 2 hours away from Gallup. So the University of New Mexico Hospital, located in Albuquerque, is the primary tertiary care referral center for this region. So most of the people who got sick were shipped to University of New Mexico Hospital. So this next slide shows the top 20 counties nationwide with the highest death rate resulting from COVID-19. So McKinley County, right here, where Gallup is again where the Navajo Nation is located, ranks 15 on this list. And the primary group that inhibits this county are American Indian descent. So this table here shows the racial makeup of New Mexico. The American Indian, or abbreviated AI group, represents only about 9% of the population. However, per 1,000 people, they are approximately 4 times more likely to contract COVID when compared to a white person, and 2 times as more likely to contract the disease compared to someone who is of Hispanic descent. Further, COVID-related deaths for this population is close to 5-fold higher in this population compared to other groups in the state. So very clearly, this data shows that the AI population is disproportionately affected by COVID-19, and there is very limiting data to describe the COVID-19 cause in this population. So to better understand the impact of SARS-CoV on disease outcomes, we conducted a prospective observational study in a cohort of hospitalized patients with COVID-19. The goal of our work was to determine whether there is a relationship between SARS-CoV viral burden and disease severity in patients of different ancestry. So our work is approved by our Human Research Protection Office. Again, patients were recruited from the University of New Mexico Hospital. Our initial enrollee was recruited approximately 1 year ago. Currently, we have 335 patients enrolled in our studies. The inclusion criteria for our study is fairly simple. If you're an adult and you're hospitalized with PCR positive COVID-19, we will approach you to be included in our study. Exclusion criteria is basically invasive mechanical ventilation at study entry, or patients or legal authorized representative who are unable to provide consent to the study. The study design is fairly simple. We gather information on race and ethnicity, as well as history of comorbidities prior to admissions through medical chart review, as well as verbal interviews with patients or the legal representatives. We also gathered clinical and lab values measured throughout admissions using, again, through medical chart review. To determine viral load in these patients, we took upper respiratory tract or URT samples and blood samples on days 0, 1, 2, 3, 6, 9, and 14 following enrollment. The URT samples consisted either of nasal swabs for non-intubated patients or nasopharyngeal swabs for patients who were intubated. And we did this just for the comfort of the non-intubated patients. So to appropriately define the multi-organ nature of COVID-19, disease severity was defined by admissions to the ICU anytime throughout the 2-week sampling period. So you're classified as non-severe if you've never been into the ICU, and you're classified as severe if you went into the ICU at any point during our 2-week sampling period, or if the patient died during this period. We also used a modified 8-category ordinal scale based on one that's adopted by the NIH to classify patient status according to oxygen requirement to capture the respiratory features of our enrollees. This is basically just one way to put a quantifiable metric into a numeric value on disease severity. So the scale starts at 1 when you're doing well and ends at 8 when you are dead. So because we're only dealing with hospitalized patient, our ordinal scale here starts at 4, and I cannot find my cursor, it's okay. When a patient is admitted to the hospital, but is on room air. And you go up on the scale depending on how oxygen is supplied to you. So if you would be a 5 if you were given low flow supplemental oxygen, and you would be a 6 if they have to crank up the amount of oxygen that they're giving to you through high flow. So I'm gonna jump right into some data. So the data that I'm gonna present today is on a subset of recruited patients, and these results are stratified on ancestry based on self-identification as well as verbal interviews. So this cohort is made up of 98 patients. I really wish I can find my cursor so I can point, but I can't. I don't know what happened to it. Okay, so they are 90 4 patients in this group. 43 of them identified themselves as AI, and everybody else in this group were classified as non-AI. 40 people in this group were female, and the mean age is 55.4. In general, the AI group were slightly younger compared to the non-AI group. It's interesting to note that the ordinal scale score between the 2 groups are very similar. That's shown right here where it says pulmonary ordinal scale score, the 3rd one from the bottom up. Also, the number of days from first SARS-CoV positive PCR tests and the number of days from initial presentation of COVID symptoms until initial sample collection between the 2 groups are very similar. Upon hospital admission, the baseline characteristics of the 2 groups are also comparable. The only difference that we saw was a slight elevation in neutrophil in the AI group and slight decrease in prothrombin time and a slight decrease in albumin in the AI group. And we didn't really think that this was too different between the 2 groups. We looked at comorbidities, right? So as you all know, there are several underlying medical conditions, including cancer, cardiovascular disease, chronic respiratory diseases, chronic kidney disease, metabolic diseases such as obesity, diabetes, might increase the risk of severe COVID-19. Most of these comorbidities, including respiratory disease, kidney disease, obesity, and diabetes, were found to be very similar between the AI and the non-AI groups. And this is shown by the yellow arrows. We do see a higher risk of cancer, coronary artery disease, and also heart failure in the non-AI group, which we thought was interesting. But in general, in our cohort, the AI group has significantly fewer overall comorbidities, which suggested to us that pre-existing conditions were not the primary cause of COVID-19 disease disparity. We also looked at other clinical events and again found nothing of significance. So then we further stratified the 2 groups into disease severity. So as a reminder, disease severity is defined as admissions to the ICU at any time throughout our 2-week sampling period. So what we saw was, using a one-sided Fisher exact test, people of AI descent are more likely to succumb to severe disease. Using a logistic regressional analysis, we were also able to determine a relationship between race and disease severity, taking into account covariates including age, sex, as well as remdesivir and steroid use. And we found that across the 14-day sampling period, the AI group was found to have more severe disease and that they have a 2.1 time longer length of hospital stay. So in summary for this chart review, what we saw was the baseline admission characteristics were comparable between AI and non-AI patients. We also found that the AI group had significantly fewer overall comorbidities, but they were found to have more severe disease and stayed in hospital for a much longer period of time. So why is this? So previous findings have indicated that elevated and prolonged detection of SARS-CoV-2 in the upper respiratory tract and in peripheral blood may promote severe disease outcomes. But again, such data is not available for our population. We therefore ask whether or not viral burden played a role in severity of disease as seen in people of American Indian descent. So to do this, we isolated viral RNA from an activated VTM. So the VTM is basically where we collect the nasal swabs or the nasopharyngeal swabs in. And we also isolated viral RNA from peripheral blood collected from these patients. We used the N1 and RNase-P primer and probe sets from the CDC 2019 nCoV PCR diagnostic panel for RT-PCRs to determine viral load. So most papers that we have found reported viral loads as CT values. However, this method may not be the most accurate way to determine viral loads, especially since we're looking at samples collected from both nasopharyngeal or nasal swabs. So when you stick the swab up all the way up your nose, right, it is more likely that you'll be collecting more cells compared to a swab on the front of your nose. So to overcome this, what we did was generated standard curves with known amount of SARS-CoV RNA and known amount of RNase-P plasmid. And we normalized our N1 probe CT value to that of the RP control. We then multiplied this number by 5 × 10⁷ copies of RP per 1,000 cell. And we took that number and log 10 transformed it to yield a quantified viral load. And these graphs are shown in the next set of plots. So the graphs that you're looking at right now show viral dynamics in either the URT, which is on the left, or peripheral blood on the right in all hospitalized patients. So to orient you, the AIs are always shown in blue, and the non-AIs are always shown in red. So the viral loads are presented as a mean, and statistical comparison of the group mean for viral loads on each of the days were performed using a Wilcoxon's rank sum test because viral loads are not normally distributed. And then we also looked at every single collection day, and we also look at an overall viral load. And to determine the overall viral load, which is indicated by the all on the graphs, we took the mean viral load per patient for all days. And this approach basically accounted for patients who were not hospitalized for the entire 2-week sampling period, and also for patients who might have died during that period. And again, this was the viral load comparison were performed using the Wilcox rank sum test. So bottom line on these plots, what we see is that in all hospitalized patients, URT viral loads were comparable between the two groups. In blood, however, the AI group had elevated viral load during initial hospitalization, as shown by the asterisks, and an overall higher viral burden across the 14 days with a p-value of 0.009. So to gain additional insight into the viral load dynamics, the two groups were further stratified according to disease severity. The graphs here show URT viral dynamics in either patients with non-severe on the left or severe disease, that's on the right. And as you can see, although the URT viral loads are lower in the AI patients with non-severe disease on day 3, all other time points and the cumulative viral burden did not differ between the non-severe or the severe disease group. This slide shows viral load dynamics in blood of either patients, again, with non-severe on the left and severe disease. In non-severe patients, peripheral blood viral loads were comparable between the AI and non-AI group. However, amongst patients with severe disease, peripheral blood viral loads were higher in the AI group on days 0, 1, and across hospitalization. We also, again, looked at logistical regression analysis, and we saw that detection of SARS-CoV-2 in peripheral blood at any time point were associated with more severe disease. And this is after we adjusted for age, sex, and use of remdesivir and steroid. And we also saw that presence of SARS-CoV-2 in blood was more frequent in the AI group. And this is an important predictor of viremia in this cohort. So in conclusion, in agreement with previous report, our study supports that hospitalized AIs suffer a more severe COVID-19 disease course when compared to people of non-AI descent. Our medical record reviews of our cohort show that baseline admission data did not play a prominent role in the increased disease severity in the AIs. And we also found that this AI cohort has significantly fewer comorbidities, suggesting that pre-existing conditions are probably not the primary cause of the disease disparity that we see. However, while URT levels were found to be comparable between the two groups, the AI patients had a higher viral load in their blood during the initial hospitalization and in the overall viral burden across the 14 days. We also, using modeling, we also saw that AI ancestry was the primary predictor of viremia, which was found to be associated with severe disease. And these results may explain in part to the increased disease severity that we see in individuals of AI descent. So our findings suggest that using viremia as an indicator, this might be a useful indicator for early treatment for this group and may therefore improve clinical outcomes for people with severe COVID-19 disease. So the work that I have presented here is actually part of a larger project. We are currently completing data pool and lab analysis for the remaining patients of our cohort. The next aim of our project is to use next generation sequencing to look at immune responses to COVID-19 in people with severe and non-severe disease. We have already sequenced about 200 samples from longitudinal time course in individuals that are stratified by disease severity and ancestries, and we are slowly starting to comb to this data. So concurrently, we are also sequencing SARS-CoV-2 that we have collected from this patient samples to determine whether or not specific viral variants may be contributing to disease disparity. So the end game of our activity is to identify prioritized gene targets and potential therapeutics for COVID-19. Once a particular pathway is identified, ex vivo experiments can be performed with saved patient peripheral blood mononuclear cells using different classes of drugs or compounds. And we would like to know whether or not these drugs can skew immunity towards a more favorable outcome for the disease. So none of this work would have been possible without all the study participants. So we offer sincere gratitude to them and their families, and also to all the nursing and support staff at the University of New Mexico Hospital, whose dedication and passion to their patients are unparalleled. Our lab team consists of a group of people with very diverse research background. So prior to the pandemic, most of us had never worked with patients, looked at a hospital record, or even heard of what a PAPR is. That for those of you who are not aware of these crazy little monkey suits that we're wearing. But just under a year into this, our team are now recruiting patients in our COVID wards. And if I can find my cursor, I can show you our director dancing in his pepper. I am very proud to be part of our amazing team at the Center of Global Health. Our team is led by Dr. DJ Perkins and includes Dr. Kunyan Cheng, Alexandra Yingling, Amber Castillo, Zion Castillo, and our amazing administrator and coordinator, Janae Martinez. Our efforts are also supported by an amazing group of physicians, statisticians, and collaborators. And with that, I thank you for your attention, and I am happy to answer any questions. Thank you. All right.
Thanks, Ivy.
You are welcome. And I cannot find my cursor, so I am so sorry.
There is some question. Oh, yeah, yes, there is one question in the chat.
Ah, there we go. Okay.
Can you read it, or you want I read it? I don't know. Marcel is recording the session, so it's good policy to read it loud. So Marco Randy asks, since URT viral load is the same between groups and the main mechanism of transmission is by the respiratory system, how do you think the blood load could be higher in AI?
So that's a great question, right? So most of us think that the virus is kind of stuck in your nose, but as you're aware, this disease, there's multi-organ involvement, right? We see kidney disease affected, the kidneys being affected, your gut is being affected, and the virus must be getting to other parts of your body by some way, right? There's no such thing as like a COVID fairy that comes around and, you know, sprinkle COVID onto your other organs. So it's very likely that the virus is traveling through the blood and going to these other organs. And for some reason, in the AI group, they're just more susceptible to these viruses being in the bloodstream. So, and it is possible that because of this, they are the ones who have the more severe disease.
I have a couple questions.
Of course.
I can start. I was curious, is this profile of comorbidities and these differences in the characteristics of the blood, like neutrophils, prothrombin time, and albumin levels, this difference, they occur in non-sick people either, or just in the people that is being hospitalized? In the general population, can you see these differences, or?
So that's a great question, Fernando. So we did the chart review and we compared basically the AI group versus the non-AI group. So your question basically is whether or not those values are similar in people who are not sick, right?
Yes.
So those numbers are actually fairly close to control numbers. For it is the prothrombin time is just slightly elevated. Usually it is at about, I think about 15 seconds. And our numbers are just slightly higher than that.
Okay, but this normally AI people has these differences when you compare to non-AI people, or?
No, not really. I think they are basically, it's basically the same in the two groups.
Okay.
Sorry, I hope I'm answering your question.
And no, that's fine. And about the comorbidities, sorry if these questions are a little bit naive, because
No.
I'm really not, how can I say, I'm not a specialist on that, but the cancer and the coronary artery disease frequency in these two populations are the same, or it's common to see a lower prevalence in AI population?
So again, when we looked at the comorbidities, we were basically comparing the patients that we had recruited. So all of these people have COVID, right? And we're basically comparing people of AI descent and to people who are not of AI descent. And in this particular population, this particular cohort, we are seeing a higher number of non-AIs with cancer, higher number of non-AIs with coronary heart disease and with heart failure.
But in the general population of those cities or in the state, you see this difference?
Again, we have not looked in a control group.
Okay.
So I don't know, basically.
Okay, okay, yeah. That's fine.
Yeah.
I'm just curious to understand if there is some difference in the basal health characteristics of these two groups.
Right. So, and that's a great question, right? So in general, people of AI descent have worse or perhaps not as good healthcare compared to people who do not live on the reservation. Their healthcare efforts are, like, unfortunately not as good. And if they have diabetes or obesity, the likelihood of them going to see a healthcare provider is much lower compared to somebody who lives in town, for example. So yeah, we would expect these people to have more comorbidities. However, when you look at people who are sick, who are affected by COVID, really, there is really not much difference between some of these diseases in people who are AI and non-AI.
Okay. There is a question in the chat. João Muzi is asking if are there other viruses or infections that are known to affect AI in more severe ways?
That's also a very, very wonderful question. The AI people, unfortunately, do suffer from some more severely in some other diseases compared to the regular population. It's very difficult to go in to the reservation and to conduct studies because they are a fairly closed society. But bottom line is, yes, they are some diseases that they are affected more severely.
Okay. There's a question from Camila Bertão. Camila, do you want to ask your question, please?
Can I, please?
Yes.
Hi, Ivy. My name is Camila. I'm a pharmacist from Maringá, Paraná. I want to know, I don't think if you know this from the patients, but like here in Brazil, we have a lot of social problems. So some groups come to the hospital. The disease is really, it can fast because it's not the beginning. Do you know if this virus from the blood samples can't be because they go to the health service later or not?
So that's a wonderful question, Carmela. What happened was when we looked at how long these people were sick before they came to hospital in the two cohorts, right, in the AI group and the non-AI group, it turns out that it was, I'm looking at the numbers now, they were like barely 1 day apart since they have been symptomatic. So what you asked is a great question because some people, they're sick, it's hard for them to get to healthcare, right? And because they live on the reservation, they honestly, some of these people do not have running water, do not have electricity, do not have way to be transported to the hospital. They stay at home until they get really, really sick, like you mentioned. But in this particular cohort, this group of people that we looked at, the amount of time that they were sick and in hospital were comparable. So honestly, it was not because they were sick longer compared to the non-AI group.
Okay, thank you, Ivy.
Of course.
Well, another question from João Musi. Do you have any tip for a biological mechanistic explanation for these differences in an AI group?
Oh.
And thank you for the excellent presentation.
Oh, thank you. That's a wonderful question, Juan. So this is what you're asking is exactly what we're starting to look at right now. So we have done RNA-seq on currently 200 of these samples. We're planning on running more RNA-seq. And in a very, very preliminary analysis of this data, it would appear that there are genetic differences that we can see in a couple of markers that is different from in the AI group when compared to the non-AI group.
Well, anybody have more questions? Or I have loads of questions, but it's good to hear the students and the other people talking. Well, I will make Marcel asked me to make you more general questions about how can I say your career, and I'm pretty curious about two things. So first is no, before that, do you think this knowledge about the AI population will be useful for the next pandemic? Is this something that it's expectable to prepare the maybe for some marker, or if you have a next COVID wave or variant or whatever happens?
Yeah, most certainly, right? So now we know that viremia, detection of virus in the blood of this population may be a marker, right? So when these people come into hospital, perhaps we can look, do a viral load in their blood. And maybe if we do see that viral load, we can start treatment much earlier rather than waiting. So since the beginning of the study to now, also realize that standard of care have changed. Now, as soon as you're admitted to hospital with COVID, they start giving you remdesivir and steroid almost right away. So when we started our study, that was not the case. So, again, that might change. Also, knowing, some of these characteristics and hopefully down the road, looking at potential medication, right? Perhaps this is something that we could recommend to the AI population and allow them treatment earlier.
Okay. Jordana, well, João says that I will look forward for your results, Dr. Ivy. Thank you again for the information. And Jordana asks, based on this data, would you recommend a differential treatment for AI population? But
so I guess that kind of swings back to what I was trying to answer earlier. So earlier on, right, people were not getting treatment as early. But now, as soon as you're admitted, they treat you with remdesivir and steroids right away. So it's because of the way treatment has changed. And nowadays, actually this past couple of weeks, the number of COVID admissions to a hospital dropped substantially. And also the thing that we've noticed is the length of hospital stay have shortened dramatically over the past couple of months. While we were actually we were collecting samples from patients for all 14 days during the initial phases of our study. Now we're only collecting samples for maybe no more than 5 days. So because of the earlier treatment, right, people might be getting better faster.
And the response with remdesivir is equal if you compare AI and non-AI populations?
Correct. So we, yeah. So some of the early, the later data that we're analyzing now, it would show that remdesivir is having a good effect in helping people heal from this disease.
Okay. So more general questions. How it was to change completely your research line of work in the last year?
So it was very interesting. It was challenging. I didn't really want to stop working on the larvicide because we were kind of on a roll, and we were, you know, moving forward and doing a lot of fun stuff. But it was almost like rising to the challenge. When COVID first hit, we were all very scared, right? And we were all sitting at home going, you know, how can we help? So lucky for us, Dr. Perkins, who is the director of our center, kind of got all of us involved. And one of the first things that we did when we went was, one of the first things we did was basically to help in recycling N95s for our hospital personnel. So that was something that we could do in our labs fairly easily. So we started out doing that, and we just kind of got more and more involved in COVID research. And so far, it's been a lot of fun. It's been challenging. It's a different type of work. Insects don't talk back to you. Patients do, because they can always say no. You can't really, you know, insects will never say no to you. Patients will tell you no, they don't want to be part of your study. And sometimes recruited patients can be difficult. They, you know, they might allow us to take samples on day 1 and day 2, and then on day 3 they decide that they no longer want to be in the study. And so yeah, so it's a different type of research, but it's been a lot of fun and it's been exciting work.
And how do we evaluate how it was to work in well, the impression that we have from the news is that it was a little bit hard to being a American scientists in the last years because of the, how can I say, the government policy, the positioning of in Brazil we have a tricky situation of having an anti-scientific government,
right?
Kind of, and I think you have I don't think it's an equal situation, but that's similar, kind of similar anti-scientific speech in administration. So how this affected your research?
It's interesting. It honestly did not affect us very much. During the lockdown, I think I probably stayed home for like maybe a week, and then we were literally back at work. It was actually kind of nice going back to work because there was plenty of parking spots. You can park very, very close to your building. And it was also nice because there was no one else there, because everybody was kind of freaking out a little bit because of the pandemic. But we were so busy that there was really no time to worry about politics. So that was kind of nice for us. We were just, you know, doing our thing, recruiting patients, learning how to work in a safe environment. And, you know, and it was, I don't know, I rather enjoyed it. But I'm strange like that.
And what about the impact of the pandemics in your research team? Because in Brazil, we, at least in Fiocruz in Rio, we had this problem of people getting sick in the labs and some casualties, you know.
Right.
Have you had this problem either?
So it's a great question. For us to go back to work, the university implemented some very strict guidelines. Like you have to sign in, you have to sign out. So they did all this tracing to make sure that everybody was safe, everybody was socially distanced when we worked. We ended up working in Tyveks and Pappers most of the time. And even when we went recruiting in the hospital, we had our Pappers on. So luckily for us, our team is pretty small, and none of us got sick from COVID. One of the buildings, actually two of the buildings, was shut down. Buildings that not buildings that we were in were shut down because of people who were sick. And so that was problematic because we can't go into those buildings, we can't use the instruments that were in the building. But otherwise, I think we did okay. It's surprising, but we actually were keeping very, very safe. The other thing that was really nice as well was the Department of Internal Medicine, where our center is part of, included us as essential workers. And so when the vaccine came out, our team was with the first group of people that got vaccinated. So that was really, really nice that they allowed us to do that.
Oh, I think I already made a lot of questions. Marcel, do you want to make any remark or comment?
Okay, yes, thank you very much, Fernando. I know that you are very have experience with seminar. You like to talk a lot, so you did my job. So I will be sacked for tonight. So maybe Fernando will continue with the seminar for the rest of the season. So it's okay. No, but thank you very much, Fernando. And Ivy, I like to do some different questions during the seminars. Maybe I would like to ask something for you. I don't know if I will be able to explain in a good way, but for example, I'm Chilean, but I have lived in Brazil for a long time. So now I'm Brazilian and Chilean. So I have children from Brazil. So I'm completely Brazilian research, and not Chilean research. But how do you feel when I believe so? You have you been living in America for a long time? Were you born in China?
So I'm Chinese, but I was actually born in Malaysia. So my family is like third or fourth generation in Malaysia. And I grew up in Malaysia. I left the country when I was 17 to come to the US to study. To go to college, basically. And I've been here now a very, very long time.
Oh, okay. So for me, my question was in related to situation with China society. Mm-hmm. So how do you feel when the pandemic is starting and the situation in how fast pass from China to the rest of the world, and this sensation as a citizen, as researcher, in related to the situation is because maybe it's the first pandemic that we have lived before. So what do you feel in related to, do you have contact with people from China, for example, and how was the feel about the first time, and now how do you believe that was controlled the situation in China and now at the rest of the world?
So I think the Chinese, based on the little bit that I know, I think they did an excellent job containing it. The contact tracing that they put in place, I think, was amazing. The speed at which they built the hospitals to house the patients, right? I mean, like, we've seen pictures where armies of people would be working to build these mobile hospitals to house their patients, and they go up in like a day or two. So I think that was amazing, and for them to be able to use contact tracing on their phones to track the disease, and how they very quickly shut down that, basically contained the disease in China, right? Unfortunately, we in the US, we cannot do that, right? The citizens of the United States would not allow like contact tracing by phone to happen. I know on our iPhones right now, there is a contact tracing app, but people are, adamantly against using that for contact tracing. I think some of the injustice that we're seeing against Chinese people in the US, I think that was kind of seeded, unfortunately, by our past president. And hopefully some of this will subside as people are hopefully coming out of that. But, I don't know if that's what you're asking.
Yeah, no, it's okay. So it's a very, very nice answer. Thank you very much for the try to put in the same situation. How do you feel about Brazilian situation now?
I feel for you guys. I think it's so tough, right? It's so obvious that this disease is devastating many of your communities, and I honestly wish that your government would encourage shutdowns and social distancing and distribution of a more effective vaccine. I do know that the Chinese vaccine, I think that's the one that you guys are using right now, may not be as effective as some of the other vaccines. And I'm not really sure if how effective that particular vaccine is against the P1 strain, and also now the P2 strain, right, that you guys have in Brazil. So yeah, I unfortunately, your government is kind of, like Fernando said, it's kind of anti, research and believing in the science, sort of like what we went through before the exchange of power in our country. I don't know. I don't know if that's an easy way to do it or not.
Yeah, no, I see. Sorry for the tricky question, because it's involving government politics, and maybe the ex-president from the United States wasn't okay, and our current government is not okay. So, but it's something to discuss between researchers all the world. So it's very important to know that science is going to sort out the problem from pandemic, and we are fighting very hard. And for me, it was a pleasure to know that you changed a little bit your field to combat the pandemic. So you are doing example. So you are the kind of scientists, the research that are trying to fight against the pandemic. So thank you very much for your time, for your talk, and I will pass the voice from Fernando, just to see if we have some other question. For me, it was a pleasure to know you, and thank you very much for your excellent talk.
Thank you very much, Marcel. And again, if any of you are interested in, doing collaborations on any of our research, please. We're always happy to collaborate. We're always happy to help. And, I love Brazil, love coming down to visit Fernando, and would be happy to help out in any way at all. Thank you.
I can confirm that collaborating with Ivy is a very good thing, okay?
Thank you.
Okay.
Advertisement. And there is do we have time for a last question, Marcel? Or
yes, we have time all the time.
Because there is a question in the chat. Marco Handy is asking, what cultural differences between Western and Eastern cultures were determinant in the well-succeed control of the pandemics in the Asian countries?
I think this is... Yeah, that's a wonderful question, right? If you look at the Asian culture, they are more, I don't know, I don't know if subservient is a good word. They listen to authority. I mean, the Chinese people, when they were told to go home and quarantine or go home and we're going to observe the shutdown, no one came out, right? Everybody stayed home. And you compare that to what was happening in the US. I mean, I have friends who till today refuse to wear a mask. And it's, it's like, because they feel that it is infringing on their rights, which is interesting, right? Because when you explain to them, look, you're not only protecting yourself, you're protecting me, right? Because I'm standing here talking to you, and you're protecting other people around you, but they just don't see that. They don't have that mentality, like some people don't. I don't think that type of a mentality is more prominent in the Eastern culture. I think people in the Eastern culture just basically listen to what the authorities tell them to do, and I think it's just it's just cultural. I'm not sure if that helps.
Oh, well. Oh, there is another question. Diogo Lima. I have a similar and more personal question for you, Dr. Ivy, in relation to the question of Professor Marcel. Both USA and Brazil had a strong anti-Chinese propaganda during all the course of COVID pandemic. And the news had shown that in USA there was a beginning of attack with some degree of violence against Asiatic descendants. Have you witnessed any of that happening with you or known people, or it's a rare situation that occurred during a short period of time?
Yeah, so so there was that spree of killing in Georgia, right, where that one gentleman went and shot a bunch of Asian people. And there have also been a lot of attacks on people of Asian descent in California. I personally have not witnessed any of this happening in Albuquerque. We are a much smaller city, right? There's only like about 1 million people. We do have a high population of Vietnamese people and some Chinese people, not a lot, but some Chinese people. We are taking the situation very seriously. The university is, starting conversations on this, how to avoid this. I think some of it may be played out of proportion, right? Because of some of the Black Lives Matter situation that is happening in the United States as well. So I think that might be part of it, and this is being rolled into that. So it could be something small and being made larger, in my opinion. Other people who are closer to it might not think so, but again, it's not something that I have faced. So yeah.
Well, it's tough discussion. Very.
No, and these are great questions. These are wonderful questions. I wish, you know, our society was more, the world is becoming so much smaller, right? Like everybody is mixed, or everybody is of different cultural descent. So I just wish that, you know, we would all just come together and fight the pandemic as a people, and not, you know, as a Black person or as a Chinese person or something else. But unfortunately, that is happening. And in the US, I believe that our previous administration had a lot to do with it. But hopefully our current administration will cause a change for the better.
Okay. Marco says, nice words, Ivy.
Oh, thank you.
Well, I think I'm already quite happy with the session and the questions. So I just want to thank you very much, Ivy.
Oh, you're
welcome.
It
was a great presentation, and congratulations on your beautiful research.
Thank you.
And thanks for the discussion. It was amazing.
Thank you so much. I really appreciate the opportunity. And just FYI, so the work that I presented, we found out about 3 weeks ago that, so we submitted a grant to the NIH to support this research. We found out about 3 weeks ago that it was accepted for funding.
Oh, congrats.
Yeah, so we're very excited about that. And again, looking for collaborators.
Okay, I will pass your contact to Marcel, and
Okay.
if you want to share your papers, especially those on COVID of the talk, and I think Marcel students will be quite happy.
Yeah, I mean,
to get this material.
Yeah, it'll be wonderful to collaborate with you guys. You know, the way things are moving in Brazil, you know, it's just like a different take on the pandemic altogether. So it would be very, very interesting to you know, study the disease process in your country, and of course the variants as well. We have connections with people who are sequencing the virus, looking at disease severity because of the mutation and things like that. So we're trying to pull all these together. So
I still want to send my students there, but it's not being allowed. maybe next year. I don't know.
No, I hope. That'll be great.
Okay, so I think we should close the session. So thank you, Ivy. Thank you, Marcel.
Thank you, Fernando. Thank you, Marcel. Thank you, everyone.
Thank you, Ivy. Thank you, Fernando. Thank you very much for everything. Ok, gente. Cuídense. Bye, bye.
Bye-bye.
Vamos a parar. Hasta la próxima semana. See you next week.
Okay, bye-bye.
Bye-bye.